Want to go to questions now. Yari had the first question. Are you able to come off mute and ask your question, Yari? I'm asking you to unmute.
Yes, hello. Can you hear me?
Yep.
Okay, so my question is, my girl is starting to stand and to cruise a little bit. And she's not spending that much time on those positions, probably 10% of her time. And it's all over the day. There is not like very specific moments that she's in those positions. And so I'm wondering, is it worth waiting a little bit more to use AFOs, or maybe start using them for short periods of time, knowing that she has one foot really pronated and her knee also is turning in?
And how old is she?
She's 3 right now.
3. Okay. Yeah. So, I mean, when I think about this, I think about sort of our typical development, and when we would be thinking about children sort of pulling up around that 9-10 month mark, and then starting to take steps at 15 months is actually more than normal, not the year that we all kind of hear about. If she's on the older side and she's just starting to pull up, I would probably opt to try to get her some stability, and see if with taking out the need for her to work on that really distal, those ankle kind of balancing and making sure she's in good alignment. If we're able to get better alignment of her knee, of her ankle, that she could focus on more of the proximal muscles, right? So she can focus on pulling up with her butt muscles, with her thigh muscles, and getting in her a better spot, and then sort of wean down however she tolerates it. But yeah, if she's 3 and she's just working on it, I think giving her some stability, and it may not look like a full AFO. I think it depends a little bit on her exam and everything. But sometimes we use SMOs, those lower ones in that position, just to give them that feedback, that proprioception, and take away some of the work they have to do all the way down at the ankle to get them moving forward.
I was especially worried about the positioning on the floor with the AFOs, because she tends to W-sit a lot, and I'm worried that would increase even more, because then it would be like kind of like something cumbersome on her butt when she's kneeling or something like that. And yeah,
it might, yeah, if she can't sit on her feet and bring them under, if she's doing that, the W sitting is always a big challenge. Often it's related to multiple factors, some that are going to be affected by the W sitting, some that are not going to be affected by the W sitting. But I think, having some time, especially if you're working with her when she's in PT, when you're working on that standing, when you're working on getting her up more, it probably makes sense to give her some support in terms of her stability at her ankle and knee.
Okay, thanks.
Thank you.
Amy, are you able to ask about when to change braces?
Yeah, and apologize, I've got my 16-month-old crying at my feet, so if you hear some tears. So I have a 6-year-old right hemi, neonatal stroke, and he walked late. He's about 2. He's walked at about 2. He's progressed super well. So he was in bilateral articulating AFOs for quite a while, and we had a new PT who was a strong brace user, and now we have a new PT for a while who was a proponent of like an under bracing. So we had a couple of different philosophies, and she's really encouraged us to consider less bracing at this point because he's progressed so well. So we've opted to, and the rehab doc was in agreement. So we've opted to go to, so now I'll have an SMO on the right, and I think it's called Chipmunk on the left. And so, they kind of looked at us as like, what do you want to do? And I have no idea. How do we think about that, right? He was doing so well and progressing so well in the AFOs, and yet we could see how strong he was when he wasn't wearing them. We've actually, once he heard, I don't need to wear them anymore, he hasn't. And so he's actually just been wearing the inserts in some Billy shoes to school, and then doesn't wear them at home. And he's actually been much more willing to go on walking further. His endurance is stronger, his strength is like everything is improved. So now we're like, okay, now we're going to end up, it's taken so long to get them. We haven't gotten them yet. We got cast in December. And I'm like, now I'm gonna have to put a brace on him. And like, I just feel like we're kind of going back and forth. And I'm just really curious how you guys think about transitioning to a different style of brace, and when and how, and what the goals are and what you think about. Because I have a feeling we're going to start having a battle when they come back, and I don't really know how to think about that.
Yeah, I mean, so Nikki and I work in a clinic together, and I feel like one of the things we talk about frequently is, you know, when the brace is spot on and we've really nailed it and they need it, they want to wear it. They want that brace on because they're able to do more, especially at the younger ages. You know, as they get into middle school, into high school, there's a little bit more pushback because there's a little bit more social pressure. But at those younger ages, you know, as Gretchen was saying with Owen, like, they're often confident. They want to go run faster. They want to play. They want to do stuff. It's not about how they look. It's about what they're doing and how they're acting. And if you frame that right for them, often wearing the brace isn't an issue. So if he's doing more, if he's more functional, if he's able to walk further, he's more interested in getting out and doing things without the brace, I think that's your answer, right? I mean, those are our goals. Our goals are not to have him in a brace. It's really to get him doing things. You know, the things that you do want to think about, and this is things that I think are a little bit challenging for me to say, is one of the little girl that was kind of running right across the screen in Nikki's, you know, she was having a lot of hyperextension at that knee. So there are certain times where we do think about maybe we're limiting a little bit of their motion, a little bit of their activity, because we're protecting a motion, right? If they're hyperextending and they're putting stress on that ligament, then we want to keep them in a more neutral position to protect that knee and not have it worsen. But if that's not the case and we're not seeing malalignment, we're not seeing issues that might progress moving forward, and they're functionally doing better with less, I mean, that's how we do it. And we watch our kids often, you know, in clinic walk without the brace first, and then we see how they are with the brace. And it's probably not the ideal way because it's more on off, but it's nice to see where they are on their own, and then see how we're helping, and see if, you know, the thoughts of what we were aiming for and what we were thinking when they're just using their body are there with the brace, or maybe there was something we wanted to do different. I think it really does depend on where that child's function is and what they're telling us and what their goals are. You know, Nikki, do you have any thoughts on that?
No, I would agree. I think one thing would be, you know, sort of looking at his alignment when he's just in shoes and barefoot, you know, thinking, sometimes I think about years ahead as well, you know, like Brian, you know, mentioned with the knee hyperextension, but the same is also kind of for the foot, you know, making sure the foot is in a good position and protected for proper development. So I think that would just be one thing I would think about in terms of sort of maintaining orthotic wear. But then to sort of balance that out, you know, there's sort of like part-time wear, right? Like he wears it sometimes, but not all the time. So then you can kind of get the benefits of both, of wearing the brace, but then the strengthening and the function without it as well for certain activities.
Yeah, great. Thanks. I mean, he definitely has some foot alignment challenges. I mean, he's got a callus on the toe that we've been trying to figure out, and he definitely pronates in when he doesn't have it in. So I do think there's some benefit, but the long game, right? I think that's part of it too, is what are we looking forward to? Okay, thank you. That was very helpful.
Edie, can you ask your question about Bioness or walk aid versus AFO?
Hi, I'm Katie. I'm a mom to a 6-year-old with right hemiplegia. One of the things that I've been looking at and researching a little bit is transitioning from an AFO to a Bioness device. And I was just wondering your thoughts and your experience with that device, because it seems to be kind of hit or miss with our different local people who are familiar or not familiar with it.
Yeah, I love the idea of it, and I love the concept of us firing, you know, activating those muscles to help with our clearance and getting us going. For people that maybe don't know what the Bioness is essentially a muscle stimulator that goes up in the upper shin and fires on the muscles that pull your toes up and it figures out how to time it in your gait cycle. So as you come through, when you come into that swing phase, it fires the muscles on the front to pull up your toe and then come through, and then it relaxes. I struggle honestly with insurance coverage with it. So I don't think about it all that frequently. I've had a few patients that we've gone down that path trying to get. I think there's probably been maybe 2 stroke patients, and then I've had maybe a transverse myelitis patient, some others that have successfully gotten it, but I do struggle getting it actually covered. The things that it doesn't do, doesn't provide any help with your plantar flexions. It doesn't provide any stability control. So you need to have those in place to make it effective. And really it works well when we have kind of generally an isolated foot drop, and you're just not getting that clearance of the foot coming through in the swing phase. If that's it, I've had a few patients that have loved it and thought it was the best thing they have. And you know, the last girl I spoke with that had it she was just early middle school. So I think she got it sometime in late elementary school, 4th or 5th grade. And like her and all her friends thought it was the coolest thing. So it worked well for her. But I will say logistically, I struggle with it sometimes.
Yeah, I don't have that much experience with it. But I do know it can be tricky getting the electrodes in the right place so that it pulls the foot straight up and not out.
Doesn't hit the perineals, yeah.
Yeah. So I think that's.
And Nikki, I'd say that's definitely another issue when we start talking about the pediatric population. So in our smaller kids that have there's just less space there, right? It's a surface electrode, so it's coming through the skin. So it's not so precise that we're putting a needle in and just firing on that single muscle. It's coming through, and if you have not much space between that tibialis anterior that pulls your toes up and some of the perineals that run along the side of it that pull your foot to the side and up, you can absolutely get a little bit of that. That's a great point. Does that help?
Yeah, thank you.
A little bit half answer.
No, it seems to be a newer thing, and they're having actually like you can do free trial periods of it for like 30 days and stuff. So just something we're looking into, because it is like a hefty cost outside of insurance. I think it's close to $5,000. So it's not,
exactly. Yeah. And that's been a huge limiting factor for us on this side. There are ways to get it. I think there's some forums on some of the stroke areas on CHASA. I think there was a forum on how to get this approved and stuff. My one patient went through all that and didn't have success. So yeah, exactly.
Awesome. Thank you.
Elise, do you want to ask your question about the delay in getting AFOs?
So maybe I can in terms of the delay, I think it depends on a 12-month, on a 1-year-old baby. So the question was, there's a 2-month delay on getting braces at 12-month-old. Is it worth going through this, or by the time we get them, will they be useless and not applicable to where that child is at this time? I think we don't typically have, there's certainly a delay from by the time you get it fit to they're made and come back. And the model that's done with Nikki is not probably the typical model anymore. It was in the past. A lot of places are now having central fabricators where they're fitting the patients either through a cast or with digital means, and then sending it out to a central place and sending it back. So there's a little bit more of a delay. I think the question is what the goals are and how kind of rapid the child's growth is and how big they are. 2 months, most braces are fitting at that age for about 6 months. And if we're still having, depending on what the goals are, if it's stability, if it is trying to get them up at 12 months, I think you can also give them some time, because, typically we would give them until they're about 15 months to start taking steps. If it's really more for just stance and that sort, and they're struggling with that part, it may make sense to get something. But there's also off the shelf things that might be beneficial at this age that could fit. Yeah, Nikki, I feel like we don't get custom for that young all that frequently.
No, it's a little early, I think, too. I think we normally do it like maybe 15 months, 18 months earliest. Sometimes we wait until they're like showing, they're starting to pull to stand themselves. Or
Yeah.
if not, you know, if it's like 18 months and they're still not doing that, then we may do, you know, kind of intervene with orthos.
I can chip in from
Yeah,
the
go ahead, please.
neurological standpoint. This is Dr. Mussolino. I'm a pediatric neurologist and stroke neurologist. I agree with both of you. At 12 months and in this transition to you, as Brian showed in the first video, a neurotypical kid will have a lot of phases in this development of gait and in getting out of the ground. And Nikki was pointing out the AFOs, even when needed, they can get into this transition. I would say at 12 months is very, very few occasions that they really need something, and it has to do more with other type of problems. It's not necessarily related directly to the stroke. So there is either a bone orthopedic ligament issue that is very specific to that child, but very infrequently we recommend bracing kids at that age. So I just ponder if you should ask a lot of questions on why and what are we trying to accomplish and what are the goals. And I don't think your delay, it probably, if there is nothing very specific to the foot or that it needs to be casted or contained or reinforced, I will argue that probably there's a lot of other sequences of development that foot needs to go through, and the sensations and movement and the toes and all that articulation has to be very flexible for the kid to really develop a proprioceptive system that allows to a very nicely coordinated gait and fine motor functions of that foot. So I got a more strong reaction to the age. And I don't know the cases specifically. We are not giving, remember guys here, medical recommendations because we don't have the patient and the history to really do it in an informed manner, and it's not the purpose of the webinars. But that I will raise there a little bit of a red flag. There's a bunch of questions you need to ask and be very clear why the baby is getting an AFO.
Yeah, and I think that, Patty, you bring up a good point in terms of the sensory aspect of things in development, right? If it is spasticity and it's range of motion that you're losing, that they're trying to control, maybe going down other paths and looking at, you know, oral medications, Botox, you know, increased therapy, nighttime bracing. There might be other ways to do it that aren't going to limit their daytime development. But
Thanks. Jordan, you have a couple questions. I'd love to have you come on camera and ask.
Hi. Oh, I'm so sorry. I'm more pale than usual. So I have a question first on like what kind of information is it like great, you know, besides pain, maybe some goals to provide at every check-in appointment for physiatry and orthotists, because we observe them, you know, all the time. And also what information maybe would be or observations for the school to observe that would inform these check-in appointments?
I love videos. You know, I think in different settings where they are when they're comfortable, if you can have videos of them, particularly front and back, from the side, seeing where they are, I think it makes it very easy. You know, how hard it is to get on and on, donning and doffing them, what that looks like, and whether it's easy to get them on. Any redness, that sort, you know, often we see patients that are coming in, it's especially if it's an 8 a.m. visit, they're not going to school. Sometimes our therapists at school are putting on braces for kids, so they're not wearing them into the clinic. When you go to these appointments, make sure you bring the braces. That's
and socks.
I know it seems silly, but it doesn't happen all the time. But you know, if you guys do know redness, you know, especially if it's the night before, if you can potentially draw a line around it, use marker to mark where it is, because we don't always see it when they come in if they have
or take a picture of it.
Or it's been on for only, you know, 5 minutes or something like that. Picture can be great, I'll tell you, especially if you're going to see your orthotist, or, you know, like our clinic, we have the orthotist there, having it on the skin, because they're sometimes able to then mark it and go make adjustments to that brace right then and there.
Marking the skin. Okay.
Can be really helpful. and just kind of how their function is, how they're overall doing, and what they're, especially as kids get older, they can give you a pretty good sense of like whether they like it, what they don't like about it. I think those are good questions and kind of a thought process to go through with it, with especially like once they hit 5, 6, 7. You know, what is better with the brace? What makes things easier? What are you faster? Is it easier to do this? What's harder with the brace? Is it hard to go up and down the stairs? Is it hard to kneel down and play, you know, do circle time, do that kind of stuff? Those are the types of things that I think we really are trying to think about as we go through when we're bracing. And it, you know, to the last question, when we think about a change in function, like should we be changing this brace? Those are the moments where we're saying, well, they feel like they're struggling when they're running, when they're walking, when they're doing all these things. And the only thing that's easier is, you know, standing. And that's a time to take it off.
So Jordan, before you go to your second set of questions, I actually want to share a question that came in on the Facebook post where I was promoting this event, which is sort of the balance of putting the brace on to improve function, like right now, versus some goal about changing the shape of the foot or how the foot is going to grow. And I know Nikki and Brian, you both touched on that a little bit, but like if the foot is pronating, is the brace, use of the brace, going to reduce the amount that the foot pronates as the child is growing?
Yes and no. Yeah, I mean, I think it can. It absolutely can if we're able to maintain range of motion, particularly in our stroke population. I think this is applicable because we do see spasticity. We see tightness in these muscles. You know, when I think about pronation and that dropping down, as Nikki did a good job kind of showing, often that's tightness within the muscles on that outside, our peroneal muscles that are pulling the outside of the foot towards the pinky toe. And then what you end up getting is a dropping of that midfoot and down. And so by maintaining that range of motion in those muscles, absolutely that can help us maintain our positioning, improve our range of motion, and potentially have longer effects in terms of how the muscles are going. All of that said, spasticity, growth, development, all of these things are moving targets in our kids. And, you know, our bones grow faster than our muscles and tendons. And so we see this kind of accordion aspect of our spasticity where we get a worsening spasticity, things get tighter as they've just had a growth spurt. We sort of catch up to it, things get better, we're in a better position, then they grow again, and we're kind of chasing it down again. And so, you know, there's certainly, when we're thinking about those types of contractures and that part, right, when we think about our plantar flexion, we're pushing down too far, wearing that brace. And when we think about night bracing, I think this is a little bit to your next question, Jordan. You know, using those to help maintain our range of motion absolutely can help with our growth and our future function to some extent. But again, that growth development is always a little bit of a moving target, and reason that we follow up on a more frequent basis than we do on the adult side.
Yeah, it's a related question is like when my son, who's now almost 7, when he was in early intervention around 2, both his really skilled early intervention and a clinical PT, who we've seen since, also thought, oh, you know what, his hand is much more affected than his foot. I think in his future, when he's an adult, not that I can predict the future, but the most I can see is like, maybe he'll wear like an insole or something like that. And now he is in a PLS. You are very familiar, Dr. Wishart. And so is it just because you don't know how a child is going to grow? Because until they grow, who knew he was going to be 90th percentile in height? I don't know. Like, and then I think like, well, what are standard things that, like, you know, for him, I think like, and it's related to that question of the least intervention to the most, is like wearing bracing more now going to prevent surgeries in the future, or I don't know, or like maybe, you know, like a lot of the forums have information, like a lot of people going through like growth and pediatric, but like what might hit, I'm middle-aged now, and like the warranty on all my parts have expired. Like what does being a hemi look like in middle age, you know, like is the arthritis, is there stuff, like what could I help him kind of prepare for?
It's a big question. It's a big,
Please
heavy
predict the
question.
future for me.
Yeah, and I think that is the challenge with it, right? Like, absolutely, it's the things that we're thinking about when we talk about alignment, right? We want to make sure the hyperextension of the knee is like the easy one. It's really the obvious one because it's very different from typical gait patterns, and most people are able to identify that. But when we think about that pronation, the times when I think about supporting that medial arch is when I start to see that kind of bowing in of the Achilles tendon. And I know that we're having upstream effects from that flat foot, right? It's affecting our ankle positioning. It's affecting how we're getting into our Achilles, and likely affecting our knee positioning, right? If our shin is in too much, we're going to be putting more pressure on the lateral aspect of that knee, setting us up for possibly some arthritis in that lateral compartment. So all of these things, I think, do need to be considered as we're going through, and it's hard to say like diffusely across the board, because to your point, Jordan, and exactly what you've seen is our kids do somewhat change, and as they grow, we may be seeing more spasticity than what we anticipated when they were very little in that calf muscles. We may see some coming up higher. I have kids that, the patterns are typical, but they're all slightly different. And some kids have more tone in their toes, and some kids have more tone more proximally. And, this isn't the forum, but Patty could speak to it. A lot of it depends on where that lesion is and where it kind of expanded into and where it's hitting the brain and the homunculus, and what, tracks we're affecting, and how much we're affecting them. So it does differ slightly to greatly from child to child. And I think having a close eye and reevaluating on a regular basis and thinking about it, right? And I think having that thought process of what are we doing and what are we affecting for the long term is important, but also making sure that we are prioritizing sort of everything, right? And I think,
Yes.
that stability is hard, right? We would love to just say, okay, Bert, we're going to keep your foot in a really stable position. We're not going to have any abnormal forces on your knee. You're not going to get arthritis later, but you're not going to be able to run. You're not going to be able to keep up with friends, and then you're going to have social concerns.
And
so,
his like kneeling and his getting up and down and the stair, who knew there would be offsets, right? Yeah.
An excellent segue, I think, for thinking about like the kid as a whole. And you guys have been touching on this. It is the role of the expert, the parents, the guardians, taking care of the kid, to step back and really be honest about what is the trade. And the only way you know what the trade is you try things. So I keep hearing here, when do we change? When do we go? Sometimes it's trial and error. I like the idea of trying things that you don't need to purchase, and having your consultant team, your physical therapist, your physiatrist, and with videos. So these people may not be at home or in school, or where you see the things that may not feel okay, or the kid start changing the behavior. Those are the things you have to document. And those are the things that you bring to your consultants and readdress and revisit, and step back as frequent as you can and see them in where they are in their life, in their development at that point. That will be the most, I would say, detailed way of doing this, without having to box them into this is the way that you need to be doing it right now because it's 6 years of age. Right. And he had a left MCA stroke. It's as Brian was saying, every kid is incredibly unique to begin with. The lesions are incredibly variable. And even anything you can read or be prescribed may need to be adapted to your child based on your expertise and experience. So we're trying to really empower you guys to work as a team, build a community, build your consultants, and work with them, and press them to see where you need to be going next, and experiment.
Maddie, you wanted to jump in?
Yeah, thanks. I love what everyone's saying. Some of the comments and the questions made me think of this child who had a traumatic brain injury and a subsequent stroke. And in my practice, a kid that I work with. And when he started pulling up to stand, and this made me think of the child whose mom asked a question, which you answered, Brian. The first question was, how old is this? How old is she? Because he was much younger when he started pulling up to stand, and he was pronating pretty clearly on his affected side. And his mom was really noticing and was really concerned. And I just, well, I knew, I had a sense that, and I want to know if you noticed this also, that when you got into a more unstable, more dynamic situation, for him to be upright, all his tone increased on his whole affected side, and he just was more, you could see it in his arm and his ribs, everything was just working a little bit more. So what I did with him was just, I was worried also about putting something on his foot that would interfere with his going up and down, because he had one way of pulling up, and I had a sense that he was kind of anxious in standing, like that he had one way of getting down to the floor safely. So we just worked on lots of different ways to go up and down, and a lot of shifting, a lot of feeling that he can bring his pelvis over, his chest over that side. And it's improved a lot over the time, and now you really don't see it except when he's running. Now when he's running, you can see a little difference, but the walking is really much more balanced. So I guess it's like thinking about this question about development. You're talking about your son, Jordan, and like how things change, right? When they grow, the bones grow, or also there's these developmental shifts functionally, right? Where this boy starts standing up for the first time, and there's more of a challenge. And then it's how do you manage that and support him to kind of to get freedom to explore and enjoy and learn in the situation. And I was curious if this idea about being in a more unstable dynamic situation, increasing tone, if you take that into consideration, or yeah, I don't know. I just was wondering if you all see that or think about that.
So I definitely saw it with Mia when Mia was first learning to walk. And I saw it more in upper extremity than lower extremity, just because Mia's less affected lower extremity. But it's like when something's novel and when there's more instability, more degrees of freedom, the nervous system is on alert, right? Like a toddler walking with all the lateral movement that Brian was talking about.
Yeah, and so that's where just, I think Brian talked a little bit about it, like giving them that distal stability can help with that tone a little bit. And sometimes, you know, if the child's supported, you can see that overflow relax a little bit and they can move a little bit easier. They can initiate swing a little bit easier. And so you give them that distal stability, and you're not necessarily locking things up. I think as an orthotist, when I look at the foot, you know, I look at them weight bearing, but then I also look at them non-weight bearing. You know, how flexible is it? How easily can I correct it? If I can correct it easily and it moves well, then it can be held there well, or you know, things can strengthen, and that's I guess as an orthotist, that's easy for me to hold on to. When things start getting fixed and stiff, then that's more difficult to address.
Well, so do you guys have that thought, that progression in your mind, like that's like, okay, like therapies, and now let's do the day brace, and now let's do the night brace that helps through growth, and then maybe Botox, and then, oh no, now it's serial casting time and surgery? Or am I not thinking about, I think I literally saw it on a sheet once. So yeah. Maybe it's completely out of context.
No, I think it's a great question, because it's certainly how the thought process was for tone management. I'm just going to share something from another lecture that I've used. So, you know, when we used to think about tone management, it really was this picture on the left where exactly what you're saying. Start with stretching, start with daytime bracing, maybe move to nighttime bracing, then maybe do casting, then do oral medication, then do Botox and casting, then do surgery, probably start with orthopedic surgeries with tendon lengthening, and then consider something like a dorsal rhizotomy or intrathecal backlift and pump. And I don't think that's the right way. And I don't think that's how we're thinking about it these days. You know, I think it's much more this picture on the right where we have a lot of modalities that we can use to help address this. And there are some more that are coming out that are less invasive, from shockwave therapy to other things. But, you know, when we think about a child, I think that we really need to think about where they are, and maybe we look different in terms of what we look like on this like spider chart, where bracing and therapy is a big part of it. We do a lot of bracing and casting, and there's some electrical stim, and maybe we have a big role of oral medications because there's really diffuse tone, and we use occasional Botox or something like that. Or maybe it's a really significant tone. They have had a lot of side effects from oral medications, and they have moved to surgery with something like a baclofen pump. I used to have another one in here that was really just focused, you know, it was really just Botox, right? It's our child that has really significant tone just in the plantar flexors, and that's it. There's no tone anywhere else, and we're struggling to maintain it with our splinting and bracing and that sort of thing. And so we just do Botox every once in a while, or maybe it's not that bad and we're able to get through it with just bracing. I think that we have to think about it much more as a combination of what makes sense at that moment, and not say, oh, we have to try oral medications before we move to focal tone management. Or maybe none of those are appropriate. Everything is, you know, they haven't done well with oral medications. They don't do well with needles. We don't have a good setup. You know, people in this talk are from all over the place. And I know bracing is very different in the UK. I met with somebody that's working with a company out there. There are no pediatrists from what I've heard out there. And the difficulty and the challenge of getting a brace that's well fit is huge. And so this model of coming in, getting it casted, having that orthotist make that brace for you and then refit it to you is a big burden. And so there's new models that are coming out there. But those are the patients that we think about. Maybe a dorsal rhizotomy is better. I have a patient from Bermuda that, you know, probably would have done fine with Botox injections, but they can't get them there. It's not available. Them flying out, it was in the middle of COVID. Their hips were getting affected. And so we did move to a rhizotomy, and they did really well with it. And so I think that there's a lot of social aspects, access aspects, and then, you know, determining what's appropriate for the child that you need to put together to fit the perfect kind of package, and not think about it as like, we have to maximize all oral medications. We have to do 1 million hours of therapy before we do something else, right? If we can cut back on therapy and get them back with their friends by doing Botox every so often, maybe it's worth that risk. Maybe it's worth that sedation, or maybe it's worth that few episodes of a needle. So those are, again, it steps back to what Patty and I were saying a second ago. We got to think about sort of that overall development and how they're progressing as a child, and how their social environment is going to be, and how their interaction is going to be when they're 20, not just right now, and how it fits as a whole. So
Thank you.
Thanks. I'm going to ask LK's question is really how to focus on dorsiflexion. Why is it so difficult to achieve? What additional tools do you use for your kids to really target dorsiflexion? Do you ever use multiple strategies to achieve dorsiflexion? I know it varies with kids. We've tried Bioness, E-stim, serial casting, Botox. Do many hemi kids just never get dorsiflexion? And if we don't, what orthopedics are we limited to? And then lastly, I wish there was an in-between SMO and AFO. This company in Minnesota makes a Go Buddy, which is a higher SMO for more support. So she's not here. She or he or they asked for the response to be recorded for later.
So there's a couple kind of clarifying that I think are a little bit challenging, but you know, in terms of dorsiflexion, I assume there's two aspects, right? Is it active dorsiflexion, or is it just our range of motion? I think the range of motion, if that's where we're struggling, that we've done Botox and serial casting and we're just not getting to that neutral point. And that, I think, is probably the most important part of this, is if we can get them to 90 degrees, that's really our biggest goal. I'd love to get more. More is more functional, but in a standard walking gait, not talking about going downstairs or upstairs, that kind of stuff. If we can be at 90 degrees, we can get ourselves to clear our foot well. We can have kind of that functional gait pattern that's not going to affect us too much. Sometimes that can be hard, to what we said before. Kids are constantly growing. if they have severe spasticity and we're getting a ton of tone into those plantar flexors, it's just going to keep pulling us down. And even if we get good improvement, they're going to have another growth spurt that's going to pull them down again. So it can absolutely be a challenge. I think the multiple modalities is the way to go about it. And if we're really struggling, I have two kids now, I think, that we've done this, we've gone through multiple rounds of Botox. We haven't had success, and we've moved to surgical intervention. And you know, at some point that may be what it is, especially in our children that are hemiplegic. Maybe they're mostly affected in their leg, and we don't want to put a ton of oral medications on board. We don't want them coming in for injections every 3 months, or we haven't had success. And honestly, in this setting, there are a couple of different options. There's some tendon lengthenings that a lot of orthopedic surgeons aren't thrilled about doing because they often aren't long-term successful, particularly in our younger kids. You lengthen that tendon, they grow, they get tight, and you're back to where you started. There's 2 places here and Wisconsin, I believe, that are doing a soleus neurectomy along with a tendon lengthen of the soleus muscle, that gastroc, which has seemed to be much more effective, where essentially you're doing a surgical Botox along with the tendon lengthening. So I think it's doable. It just sometimes takes a bit more work, and you may have to kind of move forward to a bit more aggressive measures. There certainly are middle ground things, and if you have, I feel like we ask for a high backed SMO on a regular basis, and Mickey does a great job at getting them for us.
I can add to that question. We do have some kids would not get to the 90-degree dorsiflexion, and they will become adults would not be able. They will have a little bit less than that. It is always up to the patient, the kid, and the family to really determine how much it really is either causing a long-term problem, like we were talking about, like in the knee or in the hip, and putting them at risk of something that could limit their functionality and their ability to access things. But on the other hand, right now, what are they gonna have to deal with if we really have to do surgery and things like that? I've seen a lot of patients that will choose to have not perfect dorsiflexion because they feel very comfortable with their bodies. They feel that they're accessing all the things that they really love doing, including sports and activity in school and work. And that's a good parameter. And as a younger kid, again, play, peers, playground, school, walking around, going up and down the stairs, being in the house. Those things should be taken into account to say, hey, what is that level of dorsiflexion or range of motion that we're aiming for? Going back to the very beginning of the talk, the goals. The goals need to be dynamic, guys. And you have to make them clear so you know what you're asking the providers to look into.
So we're going to try to wrap up here within about 5 minutes. I know Carla has a couple of questions about sort of how the AFO affects up above the legs and feet that we've been talking about. Do you want to ask in more detail, Carla?
Ask directly instead of just my chat.
Please.
Yes, I ask, what impact do you expect the AFO to have above the ankle for what's happening, what the child is doing at the knee or hip, or even the movement in his pelvis and spine?
Yeah, I mean, I think it's the reason that we focused on AFOs for today's talk is that it is the most effective brace we have for, I think, the least amount of bracing for the most effect. When we think about, I'm going to throw a couple of things out, but a closed chain environment. So when our foot is out in the air and we push down like into dorsiflexion, like we're pushing on the gas, that ankle goes down. But once we put that on the ground, it changes the dynamic and it changes the function of that gastroc muscle. And now it's functioning in a much different way where it's actually kind of pulling our shin back. And if you think about pulling our shin back with our knee, that can actually help us go into more of a knee extension moment and stabilize that knee to some extent. And so when we think about our braces, you know, one of the braces, the solid braces that Nikki had presented, is that ground reaction AFO that comes up in front of the shin. And really the goal of that is to get that shin back, stabilize that knee in our patients that have weakness in those plantar flexors and are crouching down and forward. And so we absolutely are thinking about what our effect is. Even that hyperextension, we're controlling where that shin goes, and absolutely controls a little bit of what we're doing. In terms of as we get higher up, you know, it's obviously gets a little bit more challenging, but affecting how that alignment is, particularly at the knee, at the ankle, can certainly have effects onto how our hips are coming in. You know, there's different aspects that I think about. I think early on with our younger kids, just having stability and getting them up on their feet is going to help protect our hips and help development of our hips in that standing position and help with that aspect of things. We have a few kids, I think, that I think off the top of my head that have had issues in terms of significant valgus where their knees are coming in really close, that we've really helped with that alignment that then comes up further and into their hips and spine. If we have leg length discrepancies, right, obviously that can set off our hips, can affect our spine, can have effects on potential scoliosis and that sort of thing. And so addressing that and being kind of complete in your evaluation and making sure that you're looking, and we do, right? We look from our hips all the way down in terms of our alignment. My typical structural exam is kind of standing, looking at their alignment, laying them down, checking their hips, whether they're in any signs of dislocation, making sure our lengths are equal in terms of our thigh bones, our shins, looking at our range of motion, at our adductors, at our hamstrings, at hip flexors, and all the way down. And so they certainly do have effects up and down. Like we could talk individually at each little spot and at length, but that's sort of a general overview. Yeah, Nikki, please.
Yeah, so I just have kind of some more, like, I guess, basic specific comments. You know, an AFO is not going to change like foot position in the transverse plane, so toe in, toe out, that comes from the tibia or the femur. So an AFO will not affect that. Sometimes the dynamics and alignment of the AFO can cause like rotation in walking. If you have a solid ankle AFO and they, at heel strike, they might have like a ski boot effect where that knee gets pushed forward. If they then have a weak hip or something, that may translate into rotation as that foot gets flat to the ground. Similarly, if the child is having trouble rolling over the toe, either because of the alignment of the AFO, the stiffness of the toe plate or something, they may rotate to help get over that toe better. So sometimes, in general, we hope that the AFO has positive effects, going up the chain, facilitating, the alignment of the knee and the hip. But sometimes it can have negative effects as well, or depending on, strength, weakness, and the alignment and dynamics of the AFO.
I really like what Brian said about time in and time out of the brace. My audio seems to have gone funny. And that feels more, I know Carla's coming from a Feldenkrais and a Knott-Bunyell method perspective, as am I, as is Maddie. So there's sort of like, what does rigidity in one part of the system do to sort of promote rigidity throughout the system? And what, if we're working on flexibility throughout the torso, how does that get affected by putting on a more rigid brace? Mm-hmm. Carla, you look like you were going to say something, and then we want to wrap it up.
Okay, so I guess my most foundational question then is, in the way that you design AFOs, is your expectation that the AFO is just holding the child in a certain position or restricting their motion, or are you designing into the AFO any ability to actually kind of proprioceptively communicate with their nervous system, so that that it gives them the information to do something different than what they were doing?
Yes, a little bit. And so a little bit of both, right? So, one is that the foot has to be in a good position to get that feedback. I don't do the tone reducing, very aggressive tone reducing modifications on that foot plate. But then I have found that, like those elastic straps I showed you are partly mechanical, partly like proprioceptive. Elastic wraparound straps around the SMOs. Mechanically, they're not strong enough or high enough to actually do anything. It just sort of that light touch is kind of like a reminder, it's almost like a little reminder, to not snap that knee back, or, to stand up, to sort of activate those extensors. So yes,
Yeah.
I think try that.
When we think about our younger kids too, and we see the kids that are struggling to get up and have that stance and that stability in their stance, sometimes just giving them that little bit of support at the ankle, where now we're putting that proprioception not just through their ankle or not just through their foot, but into the ankle. And so getting proprioceptive feedback into multiple joints from that foot, especially when they're so young and they may not be fully myelinated all the way down, where they're not getting that full, in this setting where there's delays in that. We see kids being able to focus on some of those bigger muscles and not have to coordinate all of their movements at once. And so that's sometimes our thoughts on some of those situations.
Have either of you ever made AFOs for children after they've had that SPML procedure, the selective proprioceptive myofascial lengthening, with Dr. Nuzzo or one of the people?
Selective percutaneous myofascial lengthening. Yeah, I mean, it's tendon lengthening.
How do you find those children different than the ones who've had the traditional tendon lengthening?
So, there's two doctors, Dr. Youngvi and Dr. Nuzzo, who no longer practices, that do that in the country. Dr. Nuzzo, he's not seeing new patients. Not the space for it. I can't say that I've seen a huge difference between them. I honestly have two patients that have gone out down to Texas to have it done. So I can't say 100%, but yeah.
Nicole?
All right, so
I just have a couple new patients that are new to me, and I'm still trying to figure things out for them.
thanks
Awesome.
everyone for coming. I want to thank again Brian and Nikki and invite you back to our future talks. The next one is on epilepsy in February, and then we have adaptive sports in March, acute stroke in April, and we're hoping to have a local event in person in May. So thanks again, everybody, and have a good weekend.
Thanks, everybody.